Inotuzumab ozogamicin versus standard therapy for acute lymphoblastic leukemia. Background: the prognosis for patients with acute lymphoblastic leukemia is poor. We sought to determine whether inotuzumab ozogamicin, an anti-CD22 antibody conjugate to calicamycin, result in better outcomes in patients with relapsed or refractory acute lymphoblastic leukemia than does standard therapy.
Recently, we started to move this kind of compound, before chemotherapy. In the past, there was invariable, in the majority of the patients, we do the chemotherapy before, and then we use these drugs in relapsed or refractory patients. Now we are starting to use these drugs in the frontline therapy, which is more promising because we get a rapid debulking of the disease. We get immediately restoring of clinical condition, and we can do more in our patients, for instance, getting more intensive chemotherapy later on, or bone marrow transplantation as a final consolidation of the therapy. So this is a very interesting way to use this drug. Of course, we can also use the combination of immunotherapy and conventional chemotherapy in the future in the frontline therapy. But I think it might be possible to use this drug in a very limited way in combination with chemotherapy. So the future will be without chemo.
Applications in medicine. Acute lymphocytic leukemia, also called acute lymphoblastic leukemia, is a cancer that starts from the early version of white blood cells, called lymphocytes, in the bone marrow, the soft inner part of the bones, where new blood cells are made. Leukemia cells usually invade the blood very quickly. They can then spread to other parts of the body, including the lymph nodes, liver, spleen, central nervous system, brain and spinal cord, and testicle in males. Other types of cancer also can start in these organs and then spread to the bone marrow, but these cancers are not leukemia.
Inside the hollow area of the bones is a spongy core called bone marrow. It is here that stem cells are produced. Stem cells are immature cells that can develop into components of blood. Red blood cells, which carry oxygen to the body, white blood cells, or lymphocytes, which fight infection, and platelets, which help blood to clot. Acute lymphocytic leukemia, ALL, is a cancer of the stem cells in the bone marrow that produce lymphocytes. The term acute means the cancer cells multiply rapidly, crowding out the normal cells in the blood and bone marrow. In addition, as the number of unhealthy lymphocytes in the blood and bone marrow increases, fewer red blood cells and platelets are produced. If the bone marrow is unable to produce enough healthy lymphocytes, the patient will be unable to fight infections. The leukemia cells can travel in the bloodstream or metastasize to other organs in the body, where they begin to form additional tumors. Common symptoms of ALL include persistent fever, fatigue, bleeding, easy bruising, and swollen lymph nodes. Chemotherapy is the first line of treatment aimed at destroying the leukemia cells and allowing normal blood cells to grow. Radiation therapy, biologic therapy, and bone marrow transplantation may also be used if chemotherapy is unsuccessful. Acute lymphocytic leukemia is the most common cancer in young children. However, nearly 80% of all children with ALL can be cured.
Pros. Of the 326 patients who underwent randomization, the first 218, the 109 in each group, were included in the primary intention to treat analysis of complete remission. The rate of complete remission was significantly higher in the inotuzumab ozogamicin group than in the standard therapy group. Among the patients who had completed remission, A higher percentage in the Inotuzumab ozogamicin group had results below the threshold for minimal residual disease. The duration of remission was longer in the Inotuzumab ozogamicin group.
Inotuzumab has been used in ALL in the relapse refractory setting. It is an immunoconjugate, so that means that inotuzumab has an anti-CD22 affinity, and it's combined with galecamicin, which is a sort of chemotherapy. So it targets the lymphoid cells. CD22 is very well expressed in lymphoid blasts, and then they can upload the galecamicin in order to be killed. The problem is that inotuzumab can also have some toxicities that were also described with genotuzumab, and mainly toxicity on the platelets and also toxicity on the liver. I think the study comparing inotuzumab with the best available therapy has been presented during this meeting, showing a very nice increase in the CR rate, a very nice increase in the molecular responses rates, but not so nice increase in the survival. So I think we have to move forward and perhaps to try the best way to use inotuzumab, perhaps sooner in the disease, and also perhaps to have some combinations in order to improve the survival rate for those patients.
Cons. In the safety population, the most frequent grade 3 or higher non-hematologic adverse events with inotuzumab ozogamicin were liver-related. Veno-occlusive liver disease of any grade occurred in 50 patients, 11% who received inotuzumab ozogamicin, and in one patient, the 1% who received a standard therapy.
This is a very sure and efficacy drug, so without not too much side effect. Due to the specificity of the mechanism that it works, it has not too much side effect. So it can be applied in a very old patient with acute leukemia without any other complications or any other difficulties. The majority of the patients take the drugs every week without any significant problems. And the majority of the patients respond very well. 82% of them respond very well in a short time. This is something that sometimes looks a miracle, because it works in a very rapid and selective way. So this is a very important thing for our patients.
Conclusion. The rate of complete remission was higher with inotuzumab ozogamicin than with the standard therapy, and a higher percentage of patients in the inotuzumab ozogamicin group had results below the threshold for minimal residual disease. Both progression-free and overall survival were longer with inotuzumab ozogamicin. Veno-occlusive liver disease was a major adverse event associated with inotuzumab ozogamicin.
I'm presenting today at ASCO the results of the INNOVATE trial, inotuzumab trial by age of the patients. In fact, inotuzumab ozogamicin is a monoclonal antibody that targets CD22, and it's conjugated to calicomycin, a toxin. So when the drug is bound to the CD22 at the surface of the cells, it's internalized, and then the calicomycin is delivered. That causes double DNA breakage and then death of the cells. That is how it works. We assessed the drug in leukemias in a phase 2 study where we tried to schedule 1.8 milligram per meter square monthly and then 1.8 total dose, but given in multiple divided dose, 0.8, 0.5, 0.5 weekly. Overall, in refractory patients, we found 50% responses, although the weekly regimen was found to be safer with less complication, mainly VOD and liver disturbance. That led investigators, among them ourselves and the Anderson, to take this drug into a randomized trial called INNOVATE trial, where patients were in salvage 1 or 2 were randomized to either standard of care, mostly received like either rubicin or inotuzumab on a weekly schedule. The primary endpoint was composite response rate and overall survival. We do not know the survival data yet to be presented at the EHA meeting in Denmark. We know for the responses, overall 80% responses. And then among the responders, they had an even deeper response, what we called MRD negativity. Now, as you know, the goal in ALL, when you relapse, you go for transplantation. Although that may not be the best approach for everybody, especially if you failed multiple agents, transplant will not lead to great outcome. So the concern as well, is it toxic in young people or elderly people? And the purpose of my presentation was to assess by age, and we found that age doesn't matter. The drug was equally effective and equally safe among the group of patients, the younger and the older patient. Now, one should be very careful. The drug can cause, in a small subset, veno-occlusive disease or liver damage. One should be very careful. And somebody who failed already transplant, or try not to give a drug that can cause to hepatotoxicities. I think it's a very manageable drug, quite safe and quite effective, and I look forward for the future to use it earlier than later in salvage 1 instead of waiting until multiple salvage. Why? Because my duration of response will not be as long as durable. One. Second, I may take a risk of more safety concern, so therefore we jeopardize on efficacy and safety. Therefore, my message is to use inotuzumab on a weekly dosage early on at the first salvage. Ongoing trials are assessing combination of inotuzumab with chemotherapy. We have what we call the hyper-CVD inotuzumab. We have a better responses, and we have a better, compared to single agent, longer responses and better survival. I see the future of combining, to use early on in a front line, not the relapse, in order to improve the cure rate and improve survival. I assess, in MRD setting as well, because less disease you have, earlier the drug, better is your outcome. And finally, we're exploring different schedule, lower dose schedule to minimize safety while not compromising efficacy. Thank you.
Thank you.